our program. We shall have opening of the meeting. That's what we've just done. The brief introduction, we've already handled it. And then we shall have Becca Sekatuka first, taking us through the community health workers for UHC from fragmentation to synergy. From that, we shall have Michael Semakula taking us through COVID-19 and UHC. What does this mean for intersectional vulnerabilities in health? From that, we shall have Frank Gichiza taking us through health systems and challenges they're facing. Carol Arujo, I don't know if Carol is on the call already. Will be taking us through sexual and reproductive health rights.
Yes, Jamiru, I'm on the call.
All right,
I'm present. Yes,
you're very much
thank
welcome,
you.
Carol.
Thank you.
And then we're supposed to have Jovia, though I failed to get in touch with Jovia, but unfortunately she's on the call. Fortunately, is on the call. So Jovia will also be taking us through a topic, and she will actually tell us what she's going to take us through. So for now, each panelist, you're going to take 15 minutes to present, and then the 5 minutes will be for Q&A. So later on, after all our panelists have presented their work, we shall have reactions and Q&A session in case there's someone who wants to add on something. That is the time you will use. We expect Dr. Danny Goto to say something, the likes of Mr. Dennis, Joseph Bukenya. So that is the time we've created for you to say something. I hope we are together. So right about now, we're going to start with Becca. Becca is the community health supervisor who works with Living Goods. He's also affiliated to PHM Uganda as a health activist, and he is also a global coaching fellow. As I've said, Becca is here to share with us a simple and a brief topic. And without wasting any single minute, Becca, whenever you're ready, please, you can take it on.
Thank you, Jamil, for that introduction. Well, the topic that I'm presenting today is on community health workers for universal health coverage, and from fragmentation to synergy. We are going to look at what's the contribution of community health workers? What are the challenges that they are actually facing, and what opportunities do we have, and what are their contribution in the health system, the formal health system, and then the synergy, integration, and sustainability. And then I'll conclude. So from the early years of primary health care, community-based health workers and volunteers have played a key role in satisfying the need and demand for the essential health services. The Alma Ata Declaration states that primary health care relies at local and referral levels on health workers, including the physicians, nurses, midwives, and community health workers, as well as the traditional practitioners are also inclusive. So suitably trained socially and technically to work as a health team and to respond to the expressed health needs of the community. The values and principles set down at Alma Ata continue to be relevant today, even though the primary healthcare movement has encountered difficulties in many countries and at many levels when seeking to put them into practice. And with the growing momentum for making UHC a core strategy for shaping the post-2015 global health agenda, known barriers to coverage and access must be overcome. And these are some of the barriers that I'm going to discuss. What are the noted contributions of community health workers? Community health workers extend care to underserved communities where they enhance access to health services and promote people's trust, demand, and use of such services. Since they convey the health messages more effectively. Community health workers also support service users to avoid transport costs and time by bringing the service closer to them. And in the end, they meet the needs of homebound patients, those ones who cannot actually access the health facilities. What are the challenges and opportunities? Scale up and sustainability. You will realize from experience that community health workers are recruited and supervised at the periphery of health structure, whereby NGOs that are working in community health, training, recruiting, and supervising community health workers have their own criteria of recruitment. They have their specific training needs and supervision style, irrespective of what.
Becca, sorry, Becca. Someone has asked you to put the presentation in a presentation mode. If you can do that, please. Thank you.
The other issue is the donor fund specific disease specific programs. Most of the donors fund specific programs. For instance, HIV, immunization, nutrition, maternal and child health, and this really affects training and supervision of community health workers. So we have a pool of community health workers who are doing different things, and this can affect their scale up, as in how do we actually make them enter the health system when they have various experiences. And this is being driven by the needs of the donors. Community health workers also lack career ladder or professional associations. And we've seen this, that they do not fit anywhere. They are community health workers doing different things in various organizations. So we have no career ladder. They have no professional association or body which really organizes them, which advocates for them. And the opportunity we have is that there is need for diverse training in keeping with various roles that they are performing. There is also need for synergies across initiatives and the partners, since they are all working with community health workers. There is need for working together, partnership among all those partners to support community health workers. And of course, we need to know how many community health workers we have. And also account for attrition. Attrition, those community health workers who are actually leaving their roles or their jobs because of the challenges they face. No salary, no incentives, they have personal challenges, they are parents. So there is attrition. We expect them to leave. As a community health supervisor, I've really seen many of them leaving, and they will give reasonable reasons that hold water for why they are leaving the work they really are pledged to do. Currently, we have a total of 180,000 community health workers. That is on record. But these need to be formally known and their contribution also recognized. A community health workers registry was designed by the Ministry of Health of Uganda in partnership with IntraHealth and funding from UNICEF. So this tool is a digital tool, and its aim is to register community health workers, to know their numbers, their capacity, what are they doing? As we've seen that they have a bucket of activities. Others are in maternal and child health, others are in nutrition, immunization, and the like, and working for different organizations. But this tool really identifies all their capacity and then monitors their activities at the district level. So, and the aim is to integrate them in the health system. Another challenge is the neglect of community health workers in the health workforce planning. You realize that in most countries, health workforce strategies, district and local authorities hire, manage, and support community health workers at the frontline facility and community levels without strong guidance from the national level. These are involved in recruiting community health workers, but as we said, we follow the criteria which is set by the organization that is working with community health workers, not necessarily the ministry. Multiple community health work programs have contributed to severe fragmentation. And this fragmentation is actually being brought about by the different partners operating in on different issues that we've already talked about. So there is need for explicit principles and guidance from the national level on ways of integrating and aligning these efforts to optimize synergies and build sustainable platforms for the scale up of community health work programs towards achieving universal health coverage. Another challenge is the multiple actors without coordination. UN partners working in the sphere of health have direct or indirect engagement with CHW programs and other community-based initiatives, but this is often in diverging ways. Moreover, in the same country, you realize that UNICEF is working with IntraHealth, it is working with Living Goods, it is working with BRAC, the same organization, the same UN body, but there is no alignment. These different partners have their own way of doing things, okay? And then the same partner, the UN partner, is working with them differently. So there is no coordination. The partners engaged in supporting CHWs and community-based programs are seldom present at the district or lower level. So this is also a challenge in that at the district level and the lower levels, they have their programs aligned with the their health program. But then these partners are not there. So you realize that there is no coordination. At times, that is the reason why community health workers face challenges in that the local committees or at the district level, some of them are even arrested and then, asked, what kind of work are you doing? We don't know that organization. And yet it is an organization that is taking them. So the challenge comes back to them. They don't know where they belong. They don't know who is the right person to supervise them or to report to. They work through contractors and implementers without national or local mechanisms for coordination. And that is what I'm actually talking about. The faith-based and NGO-related private or community-based CHW programs have their own arrangements for health workers, and barriers to communication between public and NGO providers are common. And I've seen this several times, whereby you go to a community with the community health workers, you are operating, and then the local leaders will ask you that we don't know you. We don't know you because you don't attend district meetings, you do not participate in any activity that is organized by the district or at the district level. So this poses a challenge to the community health worker, because the other managers may not be there, but the community health workers is in the field. If she or he is arrested, then they are directly affected. Another challenge is the fragmented disease-specific focus. So there is a difference or differences in the structure and support of interventions. And these interventions include family planning, maternal and child health, HIV, nutrition, and malaria. So this bucket of interventions poses a challenge to the community health workers in terms of recruitment, in terms of training, in terms of supervision, in terms of accountability. So you realize that not all community health workers have the same skills. They have various skills based on the specific programs that they participate in or they are involved in. And there are wide differences in training, management, and incentive structures. The results and accountability frameworks for these programs are not structured to drive synergies across initiatives. And the same issue arises, and that is synergies, because of the fragmentation. So the opportunity here is that—
Excuse me, Becca, please, you're running out of time. Kindly summarize.
Innovations piloted by partners are also not scaled up due to uncoordination. So there is also unclear link to the health system. Community health workers have no clear link to the health system. So this undermines their capacity for supervision and support, and also accountability. They are not sure who is accountable for their activities. So there is an urgent need for supervision and for support of community health workers at the level of program implementation. Another challenge is also the competing NGOs. And this is also a further barrier to synergy across CHW initiatives and partners. And we are saying that this is exacerbated by competition for funds. And if donors could incentivize cooperation, or at least make it mandatory, then this could be a tick for community health workers. There is also a challenge of unclear identity. And of course, we talked about this. They are confused of where they are, in the NGO or in the health system. So the health system hasn't approved them. The NGO, there is fragmentation. So that confusion also is there, and it deprives them of the support they need. Looking at all those challenges, the overall impact is on synergy, integration, and sustainability. So as we fight and advocate for community health workers to be included in the national health system, we have to accept and prepare ourselves to set standards for training and support of community health workers to suit the needs of the health system. Licensing bodies should be also put in place. The scope, what we've seen the scope of the activities, family planning, HIV, nutrition. So this should also be defined and also included in their scope of work. What career ladder, what career opportunities are also in place for them? So this should also be thought about. And then supervision. What kind of supervision? What level of supervision? What management will be in charge of supervision? And what capacity should they have to effectively supervise community health workers? And I would like to conclude by saying that as it was made clear in the Alma Ata Declaration, which is also valid today, community health workers, whether hired by the formal health system or selected and supported by communities, cannot be left to serve on their own. Strong leadership from the public sector is needed to facilitate alignment with the national policy frameworks and country-led coordination, and to achieve synergies and accountability, universal coverage, and sustainability. And I'm saying that to achieve universal health coverage, there is need to invest in building community health workers' skills and supporting them as valued members of the health team. Standalone investments in community health workers are no shortcut to progress. Thank you. Back to you, Jamil.
Wow, thank you very, very much. I will only have few questions. There will actually be 2 questions. Is there anyone with a question? And please, you may raise your hand or you can write it in a chat room. I can read it. I think a hand from Dennis Joseph Ukenya. Please go on.
I would really want to applaud one of our youngsters who has just joined the movement. You know, our job is to try and live by example. Thank you so much, Abubakar. I really appreciate all the efforts you've put in this and how you have been participating with us at the People's Health Movement Uganda chapter. So my question to you, Abubakar, is, do you really think that with this new model that has been assented to of the UHC, or the Universal Health Coverage, through the proposed national health insurance schemes, do you think that the community health workers will have a place in this? And if they do, what do you think they will be able to accomplish for us to have health for all? Thank you.
Thank you, Mr. Dennis. Well, to answer you on this, I believe UHC is just a building up or an addition to PHC. It is not a standalone because when you look at the primary healthcare approach, it is the approach that has proven to be working for ages. I believe we cannot achieve UHC without PHC. So it is just a contribution. Now, the issue of community health workers. The new model might, and I repeat, it might support community health workers. But as I've said, that it is just a build up on the primary health care approach, where we believe, as I started from the Alma Ata Declaration, that including community health workers, all actors, nurses, physicians, that model is actually the model that can support community health workers. So all this, unless it is building up on PHC, but as long as it is working as a standalone, then I don't see a place for us. Thank you.
Wow, thank you very much. I hope Mr. Joseph Dennis Bukenya, your question is being answered. And I'm seeing a hand from Michael. Michael, please ask your question, but please be brief. And then also, Becca, while replying to that question, you should be brief.
Hi. Thank you so much, Jamir. Mine is a comment, actually. It's not a question. And it's just a supplement on what the previous presenter has just submitted on the community health work. So in Uganda, we have already Uganda was one of those countries that ratified or participated in seconding the community health workers resolution at the World Health Assembly. And I participated in this. Through also support of Mr. Kenya from here called PHM Uganda. But you know what amuses us is the fact that we ratified these international normative guiding instruments, but we never follow up on them, or because they are not so binding. But later on in the same year, we came up with a community health workers policy, which was supposed to train community health workers throughout the 15,000 parishes in Uganda, but it was later shown. By that time, I was still at HURIC, and we tried to follow up on this, but somewhat we're told that the government didn't have enough funds to see that this policy would have a progress towards realization of well-streamlined workforce in terms of the community health workers. And so my concern here is, as a country, we've not yet owned the financing for community health workers. We are still depending on donors like Amref Africa, Living Goods, and so on and so on and so forth. And therefore, for us to have a well-motivated, commensurated, compensated, trained, appreciated, and trained community health workforce, that means the government itself has to own it, the financing for it, such that we don't have this kind of fragmentation, but also power symmetries in between, because the donors are coming up with their own programs, having community health workers. Then somewhere, somehow, we have another partner coming on board. So for us to avert them, that means we must have a proper funding mechanism towards the program, which is internally owned, before we bring in the external actors, such that we can avert that problem of fragmentation that Becca has just talked about. Thank you, Mr. Bishop.
Thank you so much. That screen that has just exited, that is Michael, when he was working with HURIC and PHM as well. Allow me once again to welcome a number of friends that are still joining us on this special day as we commemorate UHC. And we're supposed to have Michael speaking next, but we want to do gender. Oh, there is a message in the chat room from Tinash. He's saying that, thanks, Speaker, South Africa is facing a similar challenge. CHWs are on a peripheral of the health system. They are the last to get PPEs, and they are in limbo between NGO and provincial health department. Next year, PHM South Africa with partners, we taking the provincial health department to court regarding employment of the CHWs. Already, Gauteng has absorbed CHWS, but other 8 provinces are re-insisting. I think it was also a comment to our presenter. Thank you so much. We want to switch to our next presenter, and I want to invite Carol Aruko. We want to do it Kasavo Kanyama, ladies and gents. So now we want to have Caroline. Caroline is an advocate and networking officer who currently working with the Coalition for Health Promotion and Social Development, that is HEPS Uganda. She was chosen to be the People's Health Movement chairperson during the PHM conference in India, that was in 2019. And Caroline Caroline's passion is to advocate for access to SRHR commodities and medicines in different communities for vulnerable women and girls in Uganda. She's awaiting to graduate in a MPH specializing in health promotion from Uganda Matters University in Uganda. Caroline, whenever you're ready, please, you can take it on.
Thank you. Thank you, moderator, for that introduction. I must put a disclaimer, I'm traveling. So in case my network is not so clear, please bear with me. And I'm a little bit under the weather. I have a cold, so please bear all that. Thank you very much. I don't have an on-screen presentation, so I'll just speak from what I have relating to the UHC webinar celebrated today. So I hope you can all hear me.
Yes, we can hear you.
Jamiru, am I audible?
You are
okay,
audible,
thank you.
and you strictly have 15 minutes to make your presentation.
Yes, I hope I can make it in those. I'll try my best. I'll go straight in the interest of time. I'll go straight to what HEPS Uganda has been doing. I work with a coalition of health promotion and social development, and our main niche is access to essential medicines. So I think I'll speak in relation to that as well. HEPS Uganda, together with the Population Action International, we conducted an assessment of sexual reproductive health commodities, specifically looking at the family planning commodities and the supply chains, financing and procurement. And this was conducted in three countries, but of course I will focus on Uganda since I'm speaking on behalf of. This assessment was conducted in 3 countries, that is Kenya, Uganda, and Zambia. So, and of course, these 3 countries are among the 69 countries that made commitments in 2012 to develop support and strengthen the family planning programs. As we all know, there has been an increase in the funding since the commitments were made in 2012, the Family Planning Summit. So, but there has been a fluctuation in all that due to the COVID-19 constraints, which of course all that calls for domestic funding. So we have been working with Population Action International, that is PI, together with some other country-based partners like Medicines Transparency Alliance, that is META. And we undertook this assessment on the domestic, looking at the domestic sexual reproductive health and family planning financing and the supply chain landscape in the 3 countries. Yeah, so over the past 2 years, together with the civil society partners in the sub-Saharan Africa and Asia, we focused, all those have focused on the opportunities to advance the sexual reproductive health rights, including family planning, as part of the universal health coverage reform. Realizing that that vision of the UHC requires a long-term and multifaceted commitment from the different advocates, the donors, the key decision makers. There's need for a tailored action as each country leads its own unique approach. We all know that the universal health coverage, it's not a one-size-fits-all kind of thing. Each country has managed to approach it or achieve different things that were supposed to be the targets in different ways, since we have different health systems. In Uganda, different countries introduced national health insurance schemes as a core to achieve the universal health coverage financing reforms. And of course, to achieve this, we decided to have new benefit packages, and sexual reproductive health rights CSOs have also been advancing advocacy strategies to ensure sexual reproductive health and family planning services and commodities. And all these should be included and are covered by different other programs. However, as I had said earlier, we all know that that achieving the UHC and ensuring the SRHR regime, there was need for major policies and programmatic changes across the complementing parts of the country's health systems. As governments in East and Southern Africa introduce the UHC financing reforms, there's need to focus on the health insurance schemes. The policymakers also have made an effort, and there are opportunities to design financing mechanisms that deliver for both women and girls, especially the rights-based approaches that promote sexual reproductive health for women and girls by enhancing a sustainable domestic financing for family planning and many other sexual reproductive health services and commodities. However, as we all have, we know the challenge that the UHC is a little bit complex in each country because it's specific in nature. Many different people have tried to approach and achieve the targets that were that they had set in different ways. So in the different countries, for example, where HEPS conducted this analysis in assessing the family planning financing landscape that included Kenya, Uganda, and Zambia, the study kind of undertook a mapping of the supply chain and procurement to gain understanding of how family planning commodities are procured and purchased in each country, to require, and of course, this was to equip advocates with a clear picture of the current status quo in the three countries, of which the assessment was conducted. But we all know that since each country approaches this in their different ways, and amongst the three countries where this assessment was conducted, Kenya was the most populous country amongst the three, with 47.6 million people, according to the 2019 census. And coming back to Uganda, we had the most fastest growing population, one of which is also the fastest growing population globally, expanding at a rate of 3.3 and followed by the rest, Zambia at 2.9 and Kenya at 2.3. Now with Uganda's rapid growth is attributed to a high fertility rate of 5.4 children per woman. And according to our full population right now, adolescents comprise, I think, around 30% of the national population. Those are adolescents. Adolescents, I mean, from 9 to 15. Those are adolescents, or to 18. However, you want to categorize it, because they are categorized differently of late. So in Uganda, most women and girls who want to avoid pregnancy are still not able to use effective contraception, because Uganda failed to achieve the targets set in the concluded family planning course-led implementation plan that was sent in 2015-2020. Now that brings us to another challenge, because the problem I think that we have is that the investments in the family planning commodities have been twisted. For example, Uganda, out of the domestic finances invested in family planning commodities, 98% of those finances were used to procure mama kits. Totally different things. Yes, of course, they are in the sexual reproductive health line, but they are in the sexual reproductive health line, but they are not helpful in achieving the family planning target that we had set for in the family planning summit. So when we look at the impact that COVID-19 has also brought in, it has led to the diversion of the resources away from the SRHR, and the measures imposed to control it have made it difficult for women and girls to access SRHR services, leading to an increase in the unintended pregnancies. We have seen a rise in the teenage pregnancies due to the school closures. And of course, one thing leads to another, leading to even the unsafe abortions, and all these impacts on our economy. I'm going to be, we all know the top challenges as the universal health coverage that are facing. We have low levels of entitlements, the healthcare inequalities, the limited financial protections, the poor portability. All these affect us as an economy, and of course it brings a hitch in us achieving the targets that we had set, even in the Vision 2040. Yes, allow me, I promise to be that brief, and I wanted to give out just a few recommendations that I thought that we could also address in this case, that we could also take on. I think Uganda can hasten the implementation of the total market approach to family planning. We can also increase domestic resource mobilization, that is budget allocation in the fiscal planning for family planning and sexual reproductive health commodities at national and county level. And also the inclusion of the contraceptives in the existing and planned national health insurance schemes, which will of course increase access to the family planning for the insured individuals, and boosting equitable access to family planning. Yeah, I think that is all I can say for now. But in conclusion, for us to coordinate the universal health coverage, and despite the constraints that the pandemic has brought in, and us achieving the targets for the Vision 2040 and all that we had planned to, we need to move forward. For us to move forward to also include hand in hand the UHC, there's need for a political commitment and action by all sectors, and prioritization of health as the human rights issue in measurable terms, because I believe what's not reported or measured is not done. So we need ways of holding ourselves accountable, of saying that we have done this and we can measure it in this way, so we have achieved it, and then we can say, yes, this is done. I remember there's in one of the reports for WHO while they were implementing the universal health coverage, was it in 2018, the UHC, our minister, Dr. Jenna Cheng, to quote her, she said, you can't separate health from the economy and politics of the country. So I think working together and coordinating all the different sectors, the public and the private, we can surely achieve what we want. Thank you very much. Back to you, Chair.
Just to supplement on what you just said, SRHR concept is one of those most misconceived concepts in the country. And not only Uganda, but the entire continent, Africa. Like, if the young girl talked about, I need a condom, everyone will raise their eyebrows. What have you talked about? But also we can attest to the fact that most of people get to know about SRHR when they're in schools. We never get this information from our homes, you know, and that means we have so much to do in terms of engaging different stakeholders, in terms of the guardians, parents, but even the community justice actors, community gatekeepers, culture and religious leaders. All these are really imperative. I know we've been singing about this song in so many engagements. And for me, from the practical point of view, right now I'm in Nyombe and we are trying to do SRHR concerts in different districts that have humanitarian settings, and I'm actually in a camp. But let me tell you something. We've engaged people, essentially those who are coming from South Sudan, the Dinkas and the Nuas and the people from Democratic Republic of Congo. But let me tell you something. These people don't believe in your family planning. You know what they say? Any woman who engages in family planning is practicing prostitution. And secondly, they feel that it has also health implications about it. And thirdly, when a woman gives birth, for example, for them, the kind of family planning they do here, the man has his own hut, because here they're huts, right? Grass-thatched houses. So the man has his own home, and also the ladies have theirs. So when this one gives birth, you are allowed to marry another woman because you live in your own house independently, standalone house. So you don't have to get your woman. But again, we ask ourselves, so what if these people have an intercourse or intercourse at some day? Doesn't she get conceived despite the fact that there is that norm that you're not supposed to sleep with your wife in the first 2 years of the child? So for us, we see here that SRHR is still a misconceived concept in Uganda, not only even among the nations, but even the refugees. And I think helps Uganda, you must be having quite much you have to do as well in terms of engaging people who are in humanitarian contexts, essentially people from the countries that have been hit badly by humanitarian catastrophes. And that means we have to re-engage and see where we can see that all stakeholders get on the same pace. We bring them at the same pace in terms of how they understand sexual reproductive health. So family planning is really key. I posted something there in the chat that the country has registered over 1 million teenage pregnancies in just the last 2 years. Really, just 2 years. Why? Because there was lack of the information. Information was there, but not reaching to all people who need it. Essentially, those are the society periphery or in humanitarian, settings, people in the very hard to reach areas to get this information sexual reproductive. So I think information is key, but also to engage more people, but also try to do more, mapping of which areas are more vulnerable now. What are those populations that have been really left behind in terms of access to these services? We are all in Kampala in so many areas that are just doing good, but what about those others that are really left behind, hard to reach areas? So for me, I'm thinking that sexual reproductive health is really still an area that we need to do more because it contributes and aligns itself with the Sustainable Development Goal, the Sustainable Development Goals Agenda 2030, but also one of the SDG indicators we have, the SDG 3 indicator. Thank you so much. I submit.
Our next presenter is currently a programs manager at Alliance of Women Advocating for Change, AWAC Uganda. Is an enthusiastic and hardworking, multi-talented feminist and health rights advocate. Wow, your CV is very long. I'm going to be brief, so forgive me if I don't read most of the words that you wrote. Health rights advocate, researcher, writer, monitoring and evaluation specialist, and a development economist by professional who has been working in diverse range of health issues surrounding the Uganda health system, largely in SRHR, HIV, and financing for health. He holds a bachelor's degree in development economics from Makerere University. Ladies and gentlemen, join me as we welcome Michael Semakula. Michael Semakula, we've started timing you. Over to you.
And Dr. Dan says I've already submitted, right? Anyway, thank you so much, Jamir, but also I'm grateful for PHM because somehow we've revived ourselves. We went a bit mute some time back, but at least when we have such engagements, they absolutely show that we are still alive, but also we still have so many issues to go about, but also strengthening the movement in Africa and throughout the country circles. So I serve at Alliance of Women Advocating for Change, and my topic will be on COVID-19 and UHC and what it means for intersectional vulnerabilities and health. So Alliance of Women, we are an umbrella network of grassroots emerging female sex work-led organizations. We established ourselves in 2015 by a group of female sex workers, and we are in a movement. And these are our members. We're in 52 districts across the country. And our core target populations are female sex workers with multiple intersecting vulnerabilities, such as those with disability, those who injected drugs or use drugs, and there we use harm reduction mechanisms. Female sex workers who are living with HIV, those who are in refugee contexts, but also the elderly ones, and then their children, in terms of how can they cope up as well, those essential in those contexts. So my focus area will be on the key and high priority populations, and my center of discussion is on minoritized women, those who are this extreme society periphery. And as I mentioned earlier, that we work with female sex workers. And when you look at COVID-19, what has happened these days, that when we gauge ourselves in the country, how we have had these approaches in terms of pandemic prevention, response, and preparedness in the country, definitely somewhere we have left out women with intersecting and compounded vulnerabilities. For example, women who have been affected by displacement, female sex workers, women living with HIV. And this is also demystified, for example, through our rapid assessment we did last year in terms of access to sexual reproductive health services, HIV services, gender-based violence services, and so on and so forth, mental health, that are most of the pandemic response mechanisms that were done by the COVID-19 task force. We are mainly centering around mainstream populations, but are the populations that had extreme society minoritization were left behind. And the other challenges that we have as well identified that affect these populations are the SRHR services that I've talked about, access, for example, to STIs, medicines, access to condoms, access to lubricants, but also even other services that are crucial, for example, PHV vaccinations that are really important, but even vaccinations of the COVID-19, that we saw that most of this approach was on what other mainstream populations are in need of, but not having a unique approach or differentiated models of service delivery that are really critical when it comes to addressing the needs of such population and their uniqueness. And then the other non-communicable diseases that we've seen, that when you compare them with mainstream populations, the cancers, also the existing social protection policies and mechanisms available, don't ably address their needs. For example, the NHIS that left out largely women who are living with disability, but also even people with disability in their entirety, they were not ably catered for simply because maybe their uniqueness, but also the cost that is associated. Our context here, when it comes to SRHR services, for example, the population that I predominantly work with, the female sex workers, when it comes to nationally, we have 1.2 million people who are living with HIV. But also 130 people are female sex workers, and the HIV prevalence between 33 and 37%. The contraception unmet need, which as well my colleague submitted earlier, Carol Aroha from HEPS, talked about it. And as Uganda, by 2021, we had failed to hit, actually we are coming to 2022, but our unmet need is still at 30.5. But we had gauged ourselves to reach, or the benchmark to be reached was 10% by 2022, which we've not yet reached. And then also we continue as well to exhibit certain undesirable fertility rates. For example, the country is at 5.4, but this is way below when you compare it with the women who have so many multiple intersecting, challenges of vulnerabilities, like those who are disabled, that their percentage when it comes to fertility rate is at 6.8%, because we don't have unique ways through which we can enable them to access the services. For example, the deaf, the lame, those who can't access those services easily, from the facilities. And then the other is we recognize that also other factors that have been integrated in there, for example, the education level, the age, the wealth status, in terms of income disparity that exists between the populations, and those who can access the services easily, but also those who can't ably because of their income. Like our kind of income distribution in the country is not egalitarian. And then when it comes to non-communicable diseases, mortality in the country is at 1 in 3 people actually die of non-communicable diseases, which counts for 22%. Those are in cancers, cardiovascular diseases, and so on. And then when it comes to the other challenge that we have seen surrounding our health systems on health workforce, that by August 2020, this is between 2019 and 2020, that the country couldn't account for the 29,000 health practitioners. Like the absorption, those ones, where did they go? That means they were either in private sector or non-for-profit sector, or some had migrated out of that country. So the absorption is required. That means we have not yet even funded our own health workforce in order to address the poor indicators of health that are highlighted in my context. Yeah, these were the domestic resources as per 2021 in terms of financing for our health system. That health is at 2.7 trillion. That counts for 6.13%, the entire allocation of the budgets. And then these other sectors, but in yellow, that's where we have our Uganda's health system. But this means that we have not yet prioritized health, and other sectors override it, for example, security and other unproductive sectors that will take most of the expenditures. And one of the most disgusting things that the government did recently in February 2021 was to slash over 258.29 billion shillings. That is almost 23.6, right, from the last year's allocations, because they said that we didn't have enough money to fund the health sector. But remember, this is when the country needs even the funding more, because we are in a critical kind of situation due to the COVID-19, due to most of the programs that have been halted. And also we've seen the government also diverting money from sexual productive health to certain projects like the AMCHIP, which is funded by the International thought about prioritizing things that are really critical. And then the government as well continues as well to demonstrate the lack of prioritization and political action towards certain critical health indicators like SRHR and HIV. When you look at our national aid spending analysis for 2017-2019, most of the expenditures that were being carried out were through the bilateral partnerships, and that were through CDC, Global Fund, World Bank, and Global Financing Facility. And that counts for 90% of the HIV response monies being funded through or being provided through the external sources. But when it comes to domestic, we are still at 8% because the 2% comes from not-for-profit. That means we have not yet owned the funding for our own health system. And this means we can't ably move into UHC when we are still predominantly depending on the donors or the donor funding. Progress so far, what have we done so far in regards to UHC, but also enhancing health for all in Uganda? Vis-a-vis that our Abuja commitment has not yet been reached. Still, the highest is 7.9 in Uganda, and recently at 5.1, that's in the recent year. So we have the NHIs, which is the National Health Insurance Scheme, which some of our presenters have talked about in the previous summit.
Michael, your time is running up. Please summarize.
Okay, how many minutes? Oh. Hello?
Around 2 minutes, please.
So we have the NHI. However, this policy, it doesn't have a policy that to operationalize it for essentially minoritized and structurally excluded women. And then secondly, we have we still have impending colonial punitive laws and policies. For example, the Penal Code Act 136, 137, 139, but also Sexual Offences Bill. And for us, if at all we are to have UHC that is supported through policy, that means we have to address such laws and policies. Because, I mean, for the different duty bearers and policy enablers to accept the funding to go to, there must be backing policy, but also the laws. But whenever there are laws, definitely also the policy enablers can't ably accept certain things because they have, the law is in place that bans certain acts. For example, those who are engaged in female sex work, but also maybe other minorities populations like the LGBT. And then also the country has the functional disability survey, which was carried out in 2017 and 2022, which is upcoming. But also these are all to enable integrate the things of all the different critical indicators of the disability into the different programs that are upcoming in UHC. But however, these ones have not yet included so much into what the country can do in terms of the critical elements. And then I won't speak so much about Almata because it has been mentioned, but on my slide here in 2019, this is the declaration that we ratified or we participated in the United Nations Political Declaration on UHC 2019, which was focusing on so many elements. But one of the commitments that I want to talk about was on invest more and invest better by the UN member states. And this was the commitment 32 here, which is on strengthening the efforts to address communicable diseases, including HIV, tuberculosis, malaria, and so many others. But we see that our countries have not yet even invested more into sexual reproductive health services, but also investing into health indicators that are critical in order to improve people's well-being. When it comes to the investment into the UHC, that we have not yet operationalized the NHIS, because it doesn't have a backing policy, but even the government says it doesn't have enough resources to fund it. But here is the commitment that we made to, but also a resolution that the country ratified or participated in or seconded in the UN General Assembly. So that means if at all we are to have financing for health systems, all has the theme goals for this year for UHC by all the member states, essentially in Africa, but even Uganda itself, then we have to do the following. One, we have to integrate in the notion of intersectionality in all the programs that we are doing. We shouldn't look at only the mainstream populations, but even key populations, the women with disability, people living with HIV, the female sex workers, LGBTI, and even the people in humanitarian contexts. Those are all these different intersectionalities. That means intersectionality means that you must have a unique approach. What can the government do in order to see that even those people with little incomes, those who can't afford, can be able to afford this health? Which kind of package are there in terms of insurance schemes? And then secondly is to repeal the background laws and clauses that are really, impeding people's access to health services, essentially on the key populations. You know that these are colonial laws that have been placed, but even the countries where we took on these laws, they have scrapped them. Talk about UK, talk about the countries that are involved. They're no longer using those laws because they have progressed over time, but also the needs of the society. Moderator, this is my last slide, don't worry. And second, we need to identify the power centers. Your
time is up already. Please
okay, I'm finalizing. So, but also identify the power centers, which people are actually funding the government such that certain key indicators are included in these policies. For example, the NHS, who was funding the NHS in the National Insurance Scheme, such that we can put the government strong, tight tabs on it in order to increase certain elements that are critical in advancing health for everyone. And second, we need also to examine our own powers and privileges, give space for minorities, women, and HYWs, and those with the unique challenges, and have a unique approach towards UHC. And then the other is have intersectional feminist economics and approach in planning for our health system. I understand that we have the women, but women have not yet been really strong when it comes to advocating for things that are really critical in terms of their health, in sexual reproductive health, maternal newborn child health. Why? Because we've not yet built their capacities to engage, but also because we've become the voices for it. But again, it has us to empower them as well to become their own voices, which is really critical. And then the other is support the community-based NHIS. I remember in 2019, we went to in Isinjila, and we were so mesmerized with Dennis on certain community-based insurance schemes that are there. That actually people contribute a certain amount of money, about 40,000 per 4 months, and this caters for the community. And these are the community-centric models that actually we should support as the country, that instead of waiting for the NHIS, which has never seen the light because of the funding, we build on these and we support such mechanisms such that we see that everyone can access health. And then also plan to reduce the unproductive wasteful expenditures. For example, in arms and security, we don't have wars in Uganda, but we need to prioritize health because health is critical, but also one of the major resources we have as a country is the population. The population itself is.
We are going to have our next presenter, who is a project officer at Innovation for Development. She holds a bachelor's degree in environmental health science, and she has an experience of 4 years research experience, and she's passionate about working with communities. Ladies and gentlemen, join me as we welcome Jovia Gonza. Jovia, whenever you're ready, please, you can take it on.
Thank you. Good morning, everyone. I'm going to be sharing on the role of health research in the achievement of universal health coverage. I'll be giving just a few points on the factors that have been affecting research and what we could do to improve in order to achieve universal health coverage, health promotion, and health equity. So we know that research contributes a lot to health promotion, especially in terms of technology and improvement in knowledge. Over time, we have seen a development of new drugs and vaccines, for example, the COVID-19 vaccines and medical equipment that have aided in improving health of populations. And we know that as we know, the SDGs and a lot of research that has been carried out have given reference points on which topics or priority areas can be researched about, especially for low and middle income countries, which face most of the global burden of disease. But we see that although we have all this in place, low and middle income countries like Uganda, for example, are not the major recipients of grant funding for health research. And it is these gaps that and more that have limited achievement of health equity, which need to be solved so as to improve health of populations, especially low-middle income countries where research is usually carried out. Now, I'll go ahead and share some factors affecting health research, one of them being research financing. When you look at Uganda's research, you find that it is donor-driven, which means that the government of Uganda contributes very little regarding financing the health research. And then most of the funding comes from donors who are usually organizations, institutions, or individuals from developed countries such as the US, the UK, Japan, and very many others. As you can see this diagram on the screen, this was a report, a 2018 report from the East African Health Research Commission, which showed that domestic funding for Uganda was just 8%. The financing gap was 23%, and then 69% of the funding came from external donors. This limits how much we can do regarding research, including the solutions that we can provide for health problems that we face in this country. It means that we depend more on westernized solutions, if I may say, which means that we have solutions sometimes that are not context specific and therefore not sustainable enough to improve health of communities where research is carried out. We go further to explore the power imbalances in health research. You realize that high-income countries which contribute funding for our research have easy access to the funding, and they have better education and training resources, and their socioeconomic status is stable. They have a very good developmental status and stable socio-political systems, unlike developing countries like Uganda. Now, the fact that research is usually carried out in the developing countries, the lack of a conducive environment to carry out this research makes the high-income country researchers dictate the terms of research partnerships. This includes research agenda setting, where they may come in and dictate how the research should be carried out or what should be researched on. So you find that sometimes the things that are researched on are not actually the problems that are affecting communities in a country, which again brings us back to having solutions which do not solve the problems that are actually affecting communities. And then regarding dictating terms of research partnerships, we also find that they dictate publication and authorship, where you find that, for example, there is a paper written on a problem in a low and middle income country like Uganda, for example, let's say malaria, but you find that the first authors and the last authors, and these are the key authorship positions in research papers, the first and last author are usually people from the developed country or the people that funded the research and not the actual people that did data collection or wrote about the problems existing in the country. This minimizes recognition for local researchers and in some way demoralizes local researchers, especially in these research partnerships. Then there is a failure to recognize social determinants of health. Social determinants of health are usually shaped by the social, political, and economic systems in a country, and they can be better understood by the burden of diseases. Reports show that, for example, communicable diseases like HIV, malaria, and TB, although there are very many people suffering from these in the world, majority of the people living with HIV or people dying from TB and malaria are people in low and middle income countries, in addition to the now increasing burden of non-communicable diseases, which is also more in low and middle income countries. So this burden of diseases make low and middle income countries more vulnerable to being exploited during research partnerships. And therefore there is need to explore these areas in order to come up with, should I call them more equitable research partnerships where both partners can benefit, or where the partner, for example, low middle income countries that are most affected by the problem, benefit from the research, and not only the developed country benefiting in terms of recognition. After exploring these areas, I thought that these are some of the things that we can do to improve research in order to improve health and, yes, achieve universal health coverage. We know that frameworks have already been developed for research partnerships on what research partnerships should be like, but I think in addition to those, funding for research should be increased in Uganda. Recently, the government of Uganda came up with a research fund to increase funding in Uganda, and I think that is very important because it helps us fund areas that are actually being affected in health, and therefore come up with solutions that can help improve the health of communities. Then there is a need to recognize the differences in social determinants of health of research partners, especially the low and middle income countries where research is carried out. This includes examining social, cultural, and political contexts of research locations, which in the end helps us identify priority areas for research to focus on. Another key point is community-based participatory research. Research that does not include the community affected by the problem really does not help much in terms of coming up with sustainable solutions. So I think community-based participatory research meets the specific needs and aspirations of local communities, and it increases the relevance of research and strengthens partnerships in the long run. And then there is need for transparency and communication. For example, what are the goals of the research that is being carried out? How is it going to help the people? And yes, what can be best done to help the communities? Lastly, I think equity is very important, which includes recognition for all researchers, that is both researchers from low and middle income countries and those from the high income countries. And also there is respect for the different capacities of people. We know that because we are low and middle income countries, we may not be at the same level with high income countries in terms of the resources required to conduct research. But respect for different capacities and maybe meeting the gap where the other developed countries can help to improve research partnerships and research in the long run. And this includes, of course, sharing resources. And that is all I have for my presentation. Thank you very much.
Wow, a very big round of applause to you.
Thank you.
It was really a very nice and a well-researched presentation. Thank you so much. For the interest of time, I kindly beg we should rush to our next presenter because we need to hear from all of these people. We don't want to waste any single minute because we agreed to leave this webinar. We were agreed to have to leave this webinar at exactly midday. So allow me to introduce our next presenter. Allow me to introduce our next presenter. He is an environmental health specialist with experience in public health work and health research, public health work and research, I beg your pardon. He holds a bachelor's degree of environmental health science from Makerere University and is currently working as the project coordinator for innovation for development as a non-government organization. He also has a special interest in community health, sexual and reproductive health, health equity and health policy. Ladies and gentlemen, join me to welcome Frank Granson Chiza. Frank, whenever you're ready, please, the floor is yours.
Thank you, Jamil, for the introduction. Because of time, I'll try to summarize my presentation, and a good thing that most of the things have been mentioned by the previous speakers. So I'm going to take you through the systemic shortcomings within our health system that are hindering Uganda to achieve universal health coverage. When you look at I'm going to give a little background. Uganda, just like many other countries, have committed to achieving universal health coverage by 2030, as indicated in the Sustainable Development Goals. Mostly, we are looking at SDG 3, which targets at achieving health for all, where we are reducing financial risk and having access to quality health care by all people, and which is affordable. A number of policies, which include the National Health Policy too. We also have the Health Sector Development Plan, as well as the National Health Insurance Scheme that is recently the Parliament approved, but yet not passed because it's not approved by the President. Here are the few guiding frameworks we will look at for achieving universal health coverage. WHO highlights eliminating financial burden for paying for healthcare. As for Uganda, this is one of the major challenges. As you look at healthcare, is mainly the biggest percentage is out of pocket, and also it depends on donor funding, and there's very little investment on our government side, as highlighted by one of our previous speakers. But our government only invests 6% of its budget. So these frameworks will also look at expanding the coverage of health services to eligible populations. But also, when we are looking at achieving health for all, we look at the social determinants of health, which are highlighted. We have individual factors, social and community networks. Then we have all these other sectors that are at times ignored when looking at health, but then are important. You look at agriculture, education, how people are working, the living conditions, if people are employed or unemployed, water and sanitation and housing. But also we can't forget about the political influence for countries like Uganda, where things cannot move. They only move if they are politically advantageous to the regime. So you can't forget the political influence and the effect it has on the health sector and how it can help to foster achieving universal health coverage. So I will look at the journey of Uganda to achieving universal health coverage. Currently, the Ministry of Health states that at least 86% of our population are within reach of a health facility that is 5 kilometers, within 5 kilometer access. But then, yes, they may be a health facility, but most of these are faced with challenges such as lack of medicine, lack of health workers. So in the end, yes, they may have access to health facilities, but they are not getting the services that are required to meet their health needs. When you look at the global burden of disease by a study by WHO in relation to achieving universal health coverage, the indicators, you see Uganda is not doing that well, and we only have 31% according to the SDG index, and we rank at 173 in position out of 188 countries that were assessed. This was by LACENT in 2017. Here are a few indicators on how Uganda scores into the journey to achieve universal health coverage. When you look at family planning, as Carol was talking about, yes, there is work that is being done, but when you say we are not even, we are a bit halfway the journey, but there's still more work to be done, because the ideal score as a percentage is supposed to be 90%, but from the index score we have only 46%. Then you look at immunization, where we are trying, we have 78%. But other indicators, and we have tobacco smoking, we are also trying, but when you look at other indicators, hospital beds